Acute bronchitis overview. A. Characteristic symptoms and pathophysiology. Acute inflammation of the bronchi following upper respiratory tract infection, URTI, predominantly viral etiology, 90% of cases, involving pathogens such as influenza A and B, parainfluenza, adenovirus, RSV, rhinovirus, and coronavirus. Symptoms include cough, often with sputum production, chest pain, runny nose, sore throat, headache, malaise, myalgias, mild dyspnea, and occasionally fever. Cough persists for 2 to 3 weeks, typically self-limiting. Clinical presentation and diagnosis. Clinical diagnosis, based on symptomatology and auscultation findings, rhonchi, wheezing, occasional fine crackles. Diagnostics, generally not required except to exclude differential diagnoses or complications. Consider CBC, chest X-ray, CXR, and nasopharyngeal swabs in specific scenarios, e.g. atypical findings, high-risk groups. CXR may be indicated to rule out pneumonia. Findings might show peribronchial thickening. Treatment, supportive management. Emphasize rest, hydration, and avoidance of lung irritants. Symptomatic treatment. Analgesics. NSAIDs or acetaminophen for pain and fever. Antitussives, expectorants, bronchodilators, steroids, antihistamines. Not routinely recommended due to lack of proven efficacy in uncomplicated cases. Antibiotics? Not generally recommended. Reserved for suspected bacterial superinfection or alternative diagnoses like pneumonia. D. Prognosis, typically self-limiting with symptomatic treatment. Differential diagnosis. Condition, key differentiating features. Asthma, recurrent episodes, reversible airflow obstruction, wheezing. COPD exacerbation, history of COPD, increased dyspnea, increased sputum production. Pneumonia, high fever, localized chest signs. Infiltrates on CXR, bronchiolitis in children 2 years, wheezing, respiratory distress. High yield points. Acute bronchitis is mostly viral and self-limiting. Diagnostic tests are not routinely needed. Supportive care is the cornerstone of treatment. Antibiotics are not typically indicated. Differentiate from other respiratory conditions based on clinical presentation and, if necessary, imaging studies. Consider alternative diagnoses and complications in atypical presentations or high-risk patients. Clinical case, acute bronchitis. Patient information. Age, 35 years. Sex, male. Occupationless worker. Presenting complaint, persistent cough for the last 10 days. History of present illness. The patient presents with a 10-day history of a productive cough with clear to white sputum. He reports the onset of symptoms following an upper respiratory tract infection, URTI, characterized by a runny nose and mild sore throat, which resolved within a few days. The cough has persisted and is associated with occasional chest discomfort, exacerbated by deep breathing and coughing. He denies any fever, weight loss, night sweats, or recent travel. Past medical history, no known chronic diseases, non-smoker, no recent hospitalizations or surgeries. Medications, over-the-counter cough syrup with minimal relief. Social history, non-smoker, occasional alcohol consumption, works in a well-ventilated office environment. Family history, no significant family history of chronic respiratory or cardiac diseases. Physical examination, vital signs, BP 180 mm HR, 78 PM, temp 98.6 degrees Fahrenheit, 37 degrees R, 16 min. General appearance, patient is alert and oriented in no acute distress. Heme, no conjunctival pallor or icterus, nasopharynx clear, no sinus tenderness. Chest. Auscultation reveals scattered rhonchi, no wheezes, crackles, or stridor, no chest wall tenderness. Cardiovascular, regular rhythm, no murmurs or gallops. Abdomen, soft, non-tender, no organomegaly. Extremities, no cyanosis, clubbing, or edema. Diagnostic workup. Given the clinical presentation and the lack of alarming features, such as high fever, significant dyspnea, or signs suggestive of pneumonia, a conservative diagnostic approach is chosen. A chest X-ray is deferred unless symptoms persist or worsen. Assessment. The patient's presentation is consistent with acute bronchitis, likely post-viral, given the recent URTI and the symptomatology. Plan. Education. The patient is counseled about the nature of acute bronchitis, emphasizing its self-limiting course. Symptomatic management. Hydration, advised to maintain good fluid intake. Humidified air to ease coughing and sputum production. Analgesics, acetaminophen for chest discomfort as needed. Cough management, over-the-counter antitussives if the cough interferes with sleep. Follow-up. Scheduled for a follow-up in 2 weeks or earlier if symptoms worsen or new symptoms, e.g. high fever, shortness of breath, develop. Discussion. This case exemplifies a typical presentation of acute bronchitis in a healthy adult, highlighting the importance of a thorough history and physical examination in guiding management, particularly in distinguishing from more serious conditions such as pneumonia. The conservative management plan underscores the self-limiting nature of the condition and the emphasis on symptomatic relief. Oral exam questions and answers on acute bronchitis. Question 1. Q. What are the most common etiological agents of acute bronchitis in adults, and how does this guide treatment? The vast majority of acute bronchitis cases, 90%, are viral in origin, with common pathogens including influenza A and B, parainfluenza, adenovirus, respiratory syncytial virus, RSV, rhinovirus, and coronavirus. Given the viral etiology, antibiotics are generally not indicated for treatment as they are ineffective against viruses. Treatment is primarily supportive, focusing on symptom relief. Question 2. Describe the typical clinical presentation of a patient with acute bronchitis. A. Patients with acute bronchitis commonly present with a productive or non-productive cough that persists for at least 5 days to 3 weeks. They may also report symptoms of an antecedent upper respiratory tract infection, such as a runny nose or sore throat. Additional symptoms can include chest discomfort, mild dyspnea, and malaise. Fever is not typically prominent in acute bronchitis. Question 3. What physical examination findings might you expect in a patient with acute bronchitis, and how do they differ from pneumonia? In acute bronchitis, physical examination may reveal mild wheezing or rhonchi, primarily during coughing episodes, but the lungs are typically clear to auscultation between coughs. In contrast, pneumonia may present with localized crackles, dullness to percussion over the affected area, and potentially signs of consolidation such as bronchial breath sounds. The presence of significant respiratory distress, high fever, and focal lung findings on examination are more suggestive of pneumonia than acute bronchitis. Question 4. Under what circumstances should further diagnostic testing be considered in a patient suspected of having acute bronchitis? A. Further diagnostic testing in acute bronchitis is not routinely necessary unless the patient presents with atypical features or symptoms suggestive of a more serious condition, such as pneumonia or chronic obstructive pulmonary disease, COPD exacerbation. Indications for further testing may include high fever, hypoxia, marked respiratory distress, symptoms lasting longer than 3 weeks, or the presence of comorbidities that increase the risk of complications. In such cases, chest radiography, pulse oximetry, and possibly sputum cultures or spirometry may be indicated. Question 5, Q. Discuss the rationale behind the recommendation to avoid antibiotics in the treatment of uncomplicated acute bronchitis. The recommendation to avoid antibiotics in uncomplicated acute bronchitis is based on the fact that most cases are caused by viral infections against which antibiotics are ineffective. The inappropriate use of antibiotics can lead to adverse effects, antibiotic resistance, and unnecessary healthcare costs. Antibiotics may be considered in cases where there is a high suspicion of bacterial superinfection or in specific high-risk patients, but they are not indicated for routine treatment of acute bronchitis. These questions are designed to test a range of knowledge from etiology and clinical presentation to differential diagnosis and management principles, reflecting the depth and breadth expected in oral examinations for medical professionals. Half metabolic syndrome overview. A. Characteristic symptoms and pathophysiology. Metabolic syndrome is a cluster of conditions increasing the risk for cardiovascular disease and type 2 diabetes mellitus. Central feature: insulin resistance leading to hyperglycemia and dyslipidemia, associated with systemic inflammation and endothelial dysfunction. B. Clinical presentation and diagnosis. Diagnosis requires 3 of the following criteria: elevated blood glucose, fasting glucose to 100 milligram per liter, or on treatment for elevated glucose. Elevated blood pressure, systolic BP 130 millimeter Hg and or diastolic BP 85 millimeter Hg, or on hypertension treatment. Elevated triglycerides 150 milligram or on treatment for elevated triglycerides. Low HDL-C, men 40 milligrams, men 50 milligram, or on treatment for low HDL-C. Abdominal obesity, men, waist circumference 102 centimeters, 40 in, women 88 centimeters, 35 in. C. Treat lifestyle modifications. Fundamental for all patients include dietary changes, increased physical activity, and weight reduction. Pharmacotherapy, aimed at treating individual components of the syndrome. Hyperglycemia, metformin, biguanide class, particularly in prediabetes or T2DM. Hypertension, ACE inhibitors, e.g. lisinopril, angiotensin II receptor blockers, ARBs, e.g. losartan, calcium channel blockers, e.g. amlodipine. Dyslipidemia, statins, e.g. atorvastatin, simvastatin for lowering LDL and triglycerides, fibrates, e.g. fenofibrate for high triglycerides and low HDL-C. Abdominal obesity, consider GLP-1 receptor agonists, e.g. liraglutide, for weight management in the context of metabolic syndrome. D. Prognosis. Addressing individual components can significantly reduce the risk of cardiovascular events and progression to type 2 diabetes mellitus. Differential diagnosis considerations. Type 2 diabetes mellitus overlap with metabolic syndrome but diagnosed based on higher thresholds of glycemia. Cushing's syndrome features central obesity, hypertension, and glucose intolerance, but has distinct etiology and additional features like purple striae, muscle weakness. Polycystic ovary syndrome, PCOS. Women with PCOS often meet criteria for metabolic syndrome. Important to consider in differential for women with irregular menses and infertility. High yield points. Metabolic syndrome diagnosis is based on the presence of 3 specific criteria related to obesity, dyslipidemia, hypertension, and hyperglycemia. Management focuses on lifestyle changes and pharmacotherapy tailored to individual component conditions. Early intervention can mitigate the heightened risk of cardiovascular diseases and diabetes, emphasizing the importance of diagnosis and management in clinical practice. Clinical case, patient information, age 52 years, sex female, occupation school teacher, presenting complaint, routine health checkup. History of present illness. The patient comes in for a routine health checkup with no acute complaints. She mentions a gradual increase in waist circumference and expresses concern about her weight gain over the past year. She reports feeling fatigued more easily and experiencing occasional headaches. Past medical history: hypertension diagnosed 2 years ago, currently controlled with medication, no history of diabetes or cardiovascular diseases, no known allergies. Medications: lisinopril 10 milligrams daily for hypertension. Social history: non-smoker, moderate alcohol consumption, mainly on weekends, sedentary lifestyle, minimal physical activity. Family history: father had type 2 diabetes mellitus, mother has hypertension and hyperlipidemia. Physical examination: vital signs, BP 135, 85 mm, HR 78 BPM, weight 889 kilograms, height 165 centimeters. General appearance: middle-aged woman, alert and oriented. Abdomen: waist circumference measured at 102 centimeters. Cardiovascular: regular heart rhythm, no murmurs. Respiratory, clear to auscultation bilaterally. Extremities, no peripheral edema. Laboratory results, fasting glucose, 108 milligrams per milliliter, triglycerides, 160, HDLC, 48 milligrams per milliliter, LDLC, 130 milligrams per milliliter, total cholesterol, 220 milligram per. Assessment, the patient meets the criteria for metabolic syndrome, presenting with 3 out of the 5 risk factors: abdominal obesity, waist circumference, 88 centimeters, elevated blood pressure, to 130, 85 millimeter per gram, and elevated fasting glucose, 100 milligrams per deciliter. Plan lifestyle modifications, dietary counseling to adopt a healthy diet, focusing on reducing saturated fats, trans fats, and simple sugars. Increase intake of fruits, vegetables, and whole grains. Encourage regular physical activity, aiming for at least 150 minutes of moderate aerobic exercise per week. Weight management strategies to achieve a 5 to 10% reduction in body weight over the next 6 to 12 months. Pharmacotherapy. Continue lisinopril for hypertension and reassess dosage in follow-up visits. Consider initiating metformin if fasting glucose levels increase, indicating progression towards type 2 diabetes mellitus. Discuss the potential need for lipid-lowering therapy, such as statins, in future consultations based on LDL-C levels and overall cardiovascular risk assessment. Follow-up. Schedule a follow-up visit in 3 months to monitor blood pressure, lipid profile, and glucose levels, and to evaluate the effectiveness of lifestyle modifications. Annual screening for type 2 diabetes mellitus and cardiovascular risk assessment. Discussion. This case illustrates a common presentation of metabolic syndrome characterized by a constellation of cardiovascular risk factors. It underscores the importance of a comprehensive approach, including lifestyle modifications and pharmacotherapy, to manage individual risk factors and prevent the progression to more severe conditions such as type 2 diabetes mellitus and cardiovascular disease.
Version of the information: metabolic syndrome, a cluster of conditions that occur together, increasing the risk for heart disease, stroke, and type 2 diabetes. Diagnostic criteria: presence of 3 or more. Abdominal obesity, waist circumference greater than or equal to 102 centimeters for men, greater than or equal to 88 centimeters for women. Elevated fasting glucose, greater than or equal to 100 milligrams per deciliter, or on treatment for hyperglycemia. Elevated blood pressure, systolic BP greater than or equal to 130 millimeters of mercury, or diastolic BP greater than or equal to 85 millimeters of mercury, or on treatment for hypertension. High triglyceride levels, greater than or equal to 150 milligrams per deciliter, or on treatment for hypertriglyceridemia. Low HDL cholesterol, less than 40 milligrams per deciliter for men, less than 50 milligrams per deciliter for women, or on treatment for low HDL-C. Pathophysiological mechanisms. Insulin resistance. Cells fail to respond normally to insulin, leading to hyperglycemia and compensatory hyperinsulinemia. Obesity, especially abdominal obesity, increased free fatty acids exacerbate insulin resistance and are associated with dyslipidemia. Inflammation and endothelial dysfunction. Adipose tissue secretes pro-inflammatory cytokines, contributing to systemic inflammation and endothelial dysfunction. Dyslipidemia, high triglycerides, low HDL-C, and increased small, dense LDL particles contribute to atherogenesis. Metabolic syndrome management. Lifestyle modifications. Diet changes reducing saturated fats, trans fats, and simple sugars. Increased physical activity, at least 150 minutes of moderate exercise per week. Weight loss, 5 to 10% of body weight. Pharmacotherapy. Antihypertensives, ACE inhibitors, ARBs, for high blood pressure. Statins for dyslipidemia. Metformin for glucose intolerance or diabetes. Monitoring and follow-up. Regular checks of blood pressure, lipid profile, glucose levels, and weight. Continuous encouragement for lifestyle adherence. Insulin resistance in metabolic syndrome. Role: key underlying mechanism leading to hyperglycemia, increased insulin levels, dyslipidemia, and hypertension. Management. Lifestyle changes. Reduce simple sugars, increase fiber intake, and engage in regular exercise to improve insulin sensitivity. Pharmacological interventions. Metformin, biguanide, lowers blood glucose levels and enhances insulin sensitivity. Thiazolidinediones, TZDs, can also improve insulin sensitivity but are used cautiously due to side effects. Comparison with single risk factor, e.g., hypertension. Integrated approach. Metabolic syndrome management targets multiple risk factors holistically, including lifestyle modifications. Pharmacotherapy addresses both individual risk factors and overall syndrome components.
Hirschsprung disease overview. A. Characteristic symptoms and pathophysiology. Hirschsprung disease is characterized by a segment of the colon lacking ganglion cells, leading to functional obstruction due to the inability of this segment to relax. The aganglionic segment usually involves the rectosigmoid region, but can extend proximally to varying lengths. Pathophysiology involves defective migration of neural crest cells during development, resulting in absent Meissner's and Auerbach's plexuses. B. Clinical presentation and diagnosis. Early signs: delayed passage of meconium 48 hours after birth, abdominal distension, and bilious vomiting. Diagnostic modalities: contrast enema identifies the transition zone between normal and aganglionic segments, may show a narrow distal bowel with proximal dilation. Anorectal manometry, absence of the rectoanal inhibitory reflex, rare. Rectal biopsy, definitive diagnosis with absence of ganglion cells and increased acetylcholinesterase staining in the mucosal and submucosal layers. C treatment: surgical resection. The aganglionic segment is removed and continuity of the bowel is restored, typically via a pull-through procedure such as the Soave or Swenson technique. Key to preserving anal sphincter function to prevent incontinence. Pre- and post-operative care. Initial management includes IV fluids for hydration, nasogastric decompression, and antibiotics if enterocolitis is suspected. Postoperative management: regular follow-ups for monitoring bowel function, growth, and development. Colonic irrigations might be necessary to manage stool passage in the early postoperative period. D. Prognosis: generally good with timely surgical intervention. Key prognostic factors include the length of the ganglionic segment and the presence of complications such as enterocolitis. Differential diagnosis table. Key differentiating features: intestinal neuronal dysplasia, similar presentation but characterized by hyperganglionosis. Diagnosis also made via rectal biopsy. Meconium ileus, often associated with cystic fibrosis, characterized by obstruction due to inspissated meconium in the ileum. Meconium plug syndrome, transient condition with meconium plug obstructing the intestine, less severe than Hirschsprung and often resolves spontaneously. Congenital hypothyroidism, presents with feeding difficulties, hypotonia, and prolonged jaundice, diagnosed by neonatal screening. Points: Hirschsprung disease involves the absence of enteric ganglion cells, predominantly affecting the rectosigmoid region and leading to functional bowel obstruction in neonates. The key to diagnosis includes identifying the transition zone via contrast enema, absence of rare in anorectal manometry, and lack of ganglion cells on rectal biopsy. Surgical resection of the ganglionic segment with preservation of anal sphincter function is the definitive treatment, offering a favorable prognosis with early intervention. Clinical case: Hirschsprung's disease. Patient information: newborn, 3 days old, sex, male, birth history, full-term delivery via spontaneous vaginal delivery, no complications during pregnancy or delivery. Presenting complaint. The neonate has not passed meconium since birth and has developed progressive abdominal distension. History of present illness. The mother reports that the newborn appeared healthy at birth, but became increasingly irritable with noticeable abdominal swelling. The infant has had episodes of bilious vomiting since the second day of life. Physical examination. General. Irritable infant with noticeable abdominal distension. Abdomen, distended, palpable bowel loops, no visible peristalsis, tympanic on percussion. Anus, normal appearance, tight anal sphincter on digital rectal examination, with a small amount of meconium expelled after examination. Other systems, examination findings unremarkable. Initial investigations, abdominal X-ray shows dilated bowel loops with a paucity of gas in the rectum, suggesting a distal obstruction. Contrast enema demonstrates a transition zone in the rectosigmoid area with proximal colonic dilatation. Clinical course. Given the clinical presentation and initial investigative findings, Hirschsprung's disease is highly suspected. The neonate is managed initially with nasogastric decompression and intravenous hydration. Definitive diagnosis. A rectal biopsy is performed, revealing the absence of ganglion cells in the submucosa and increased acetylcholinesterase activity, confirming the diagnosis of Hirschsprung's disease. Treatment. The neonate undergoes a surgical procedure for Hirschsprung's disease, specifically a total transanal endorectal pull-through procedure, with the ganglionic segment resected and normal ganglionic bowel pulled through to the anus. Postoperative care. The neonate is closely monitored for signs of enterocolitis and other complications. He receives regular follow-ups to assess bowel function and development. Outcome. The neonate shows good recovery with successful passage of stool postoperatively. The parents are educated about signs of enterocolitis and the importance of regular follow-ups to monitor the child's growth and bowel function. Discussion. This clinical case highlights the typical presentation of Hirschsprung's disease in a newborn, emphasizing the importance of early recognition and intervention. The case demonstrates the diagnostic approach, including the pivotal role of rectal biopsy and the effectiveness of surgical treatment in resolving the obstruction and improving the patient's quality of life. Exam questions and answers on Hirschsprung's disease. Question 1. Q. Describe the pathophysiological mechanism underlying Hirschsprung's disease. Hirschsprung's disease is caused by the failure of neural crest cells to migrate fully during intestinal development, resulting in a segment of the bowel, most commonly the rectosigmoid region, that lacks ganglion cells in the myenteric and submucosal plexuses. This absence of ganglion cells leads to a lack of peristalsis in the affected segment, causing functional obstruction and accumulation of stool proximal to the aganglionic segment, which can lead to megacolon. Question 2. Q. What are the key clinical features and initial diagnostic steps for a newborn suspected of having Hirschsprung's disease? Key clinical features in a newborn suspect for Hirschsprung's disease include failure to pass meconium within 48 hours of birth, abdominal distension, and episodes of bilious vomiting. Initial diagnostic steps typically involve an abdominal X-ray, which may show distended bowel loops with a transition zone, and a contrast enema to delineate the transition zone more clearly and estimate the length of the aganglionic segment. However, definitive diagnosis requires a rectal biopsy showing the absence of ganglion cells. Question 3. Explain the surgical management of Hirschsprung's disease and its importance in the treatment plan. A. Surgical management of Hirschsprung's disease involves the removal of the aganglionic segment of the bowel and reestablishing bowel continuity with the normal ganglionic segment. The most common surgical approach is the pull-through procedure, where the normal ganglionic bowel is pulled through the aganglionic segment and anastomosed to the anus. This procedure restores bowel function by allowing the normal ganglionated segment of the bowel to control defecation. Maintaining the integrity of the internal anal sphincter during surgery is crucial to preserve continence. This surgical intervention is essential as it resolves the functional obstruction and prevents complications associated with the disease, such as enterocolitis and toxic megacolon. These questions are designed to assess understanding of the complex nature of Hirschsprung's disease, covering its pathophysiology, clinical presentation, diagnostic approach, and the critical role of surgical intervention in management. Oral exam questions and answers on Hirschsprung's disease. Question 1. Q. Describe the pathophysiological mechanism of Hirschsprung's disease and explain why the rectus sigmoid region is most commonly affected. Hirschsprung's disease is characterized by the absence of ganglion cells in the myenteric and submucosal plexuses of the distal intestine. This condition results from a failure of neural crest cells to migrate, proliferate, differentiate, or survive in the affected intestinal segment during embryonic development. The rectus sigmoid region is most commonly affected because it is the last area to be colonized by neural crest cells during embryonic development, making it more susceptible to a ganglionosis. The absence of these cells leads to a lack of peristalsis in the affected segment, causing functional intestinal obstruction. Question 2. Explain the significance of the transition zone in Hirschsprung's disease and how it is identified. The transition zone in Hirschsprung's disease refers to the area where the normal ganglionated bowel transitions to the aganglionic diseased segment. This zone is crucial for diagnosing Hirschsprung's disease and planning surgical intervention. It is identified radiographically during a contrast enema where a visible change in caliber is seen between the proximal dilated ganglionated segment and the distal narrowed aganglionic segment. Identifying this transition zone accurately is essential for effective surgical resection of the ganglionic segment and anastomosis of the healthy bowel to the anal canal. Question 3. Discuss the management of Hirschsprung-associated enterocolitis, HAEC, and why it's a critical consideration in the post-operative care of patients with Hirschsprung's disease. A. Hirschsprung-associated enterocolitis, HAC, is a severe, potentially life-threatening complication of Hirschsprung's disease. Management includes aggressive hydration, intravenous broad-spectrum antibiotics, covering both anaerobic and aerobic bacteria, and rectal irrigation to decompress the bowel and remove fecal stasis and bacterial load. In severe cases, surgical intervention may be necessary to resect necrotic bowel segments or perform an ostomy. AIG requires vigilant monitoring in the post-operative care of patients with Hirschsprung's disease because the risk persists even after the aganglionic segment has been resected. Early recognition and management of HAE symptoms are critical to prevent progression to toxic megacolon, sepsis, and potentially fatal outcomes. These questions delve into the underlying mechanisms, diagnostic considerations, and management challenges associated with Hirschsprung's disease, reflecting the depth of understanding expected from medical professionals in a specialized pediatric setting.